Hello everyone, in this video we'll discuss about the chemical examination of the urine. In my previous video we discussed about the physical examination and the microbiological examination. Now going to the chemical examination, we can check for protein levels, glucose level, ketone bodies, bile salts, urobilinogen in urine and various other chemicals. Here we'll discuss firstly about the proteins. Now normally the kidneys, they secrete a scant amount of protein in the urine because the protein, they are large in size and also they are negatively charged, so very less amount of protein is present in the urine. However, sometimes protein which are present in the urine, normally they are derived from the plasma or either from the urinary tract, and one of such protein is stem horsefall protein, and this stem horsefall protein is just a normal mucoprotein which is secreted by the loop of the Henle. Now going to the abnormal presence of proteins in the urine is known as proteinuria, and its excretion should be greater than 150 milligram per 24 hours in adults. And there are many causes of proteinuria. We will discuss according to the pathogenesis, that the pathogenesis can lie in glomeruli, it can lie in the tubules and various other things. Now going to the firstly the glomerular proteinuria. Now the glomerular proteinuria, the cause is in the glomeruli due to the increased permeability of glomerular capillary walls, and according to the course of the disease, it can be divided into two types. First is the selective and second is the non-selective. Now, what is selective proteinuria? It means when the disease is early in onset, the glomeruli, it can retain the large molecular weight proteins because the damage is not so much, but lower molecular weight proteins, they are excreted into the urine, and such is known as selective. However, late in the course of the disease, this selectivity is lost, and also now larger molecular weight proteins, they will also be excreted. This is known as non-selective proteinuria. Second pathogenesis, the problem can lie in the tubules. Now normally the glomerular membrane, it stops the higher molecular weight proteins to go into tubules, but some lower molecular weight proteins, they can be passed into the tubules, and such proteins, they are actively reabsorbed by the tubules. In case of tubular diseases like pyelonephritis, like in case of rejection of renal transplant, this type of proteinuria can be seen due to abnormality present in the tubules. Third pathogenesis can be due to overflow. It means when a concentration of a protein rises in the plasma, it automatically overflows into the urine because it is increased, there is increased level of such protein present in the plasma, and such is the case seen during multiple myeloma due to increase in the level of immunoglobulin light chain, or which is also known as Benz-Jones proteins. These proteins can be seen in the urine. Now, what are Benz-Jones protein? They are the immunoglobulin light chains, and it is seen in multiple myeloma. But also, they have a very characteristic thermal behavior. What is the characteristic is that when we take a sample having these proteins, and when this sample is heated, the proteins, they tend to precipitate between the temperature of around 40 to 60 degrees Celsius, and when we keep on heating the sample, the precipitate, it disappears around 100 degrees Celsius. This precipitate will disappear. However, when this sample is again cooled, there is reappearance of the precipitate of the Benz-Jones protein. However, this is a very crude method, and now to check for Benz-Jones proteins, the protein electrophoresis is done. Now the next cause of proteinuria can be just hemodynamic, which is seen during high fever, heavy exercise, exposure to the cold, due to any alteration in the blood supply to the kidney, the proteinuria can be present. Another specific type of proteinuria is postural proteinuria, and such proteinuria occurs only when the subject or the patient keeps on standing or is ambulatory, but it is absent after a recumbent position. So to test it, we take the first morning urine sample and it is negative for proteins. However, when the sample is collected after the normal daily activities in the evening, the sample it is positive for the proteins. Lastly, the cause of proteinuria can be due to any post-renal causes due to inflammation present in the ureter, bladder, prostate or urethra. This was all about the causes. Now going to the test to detect it. The test to detect is firstly the qualitative test, just to see either the proteins are present or absent. First is the heat and acetic acid test, and this is based on the principle that the proteins they get precipitated when we boil them in an acidic solution. That means the urine sample should be slightly acidic, and then we boil it, then the proteins will be precipitated. For this, we take a test tube. This is a test tube, and we fill it 2/3 with the urine sample, and then the upper portion of the urine sample that is heated, and then we will look for precipitation of the proteins. The upper part, if shows precipitates or is cloudy, this shows the presence of proteins. However, the upper part should be compared with the lower part for a better comparison. Then second test which we can use is reagent strip test, which is most commonly used to check for the presence of proteins, because the strip is coated with an indicator which changes its color. Third is the sulfosalicylic acid test. Now sulfosalicylic acid, when is added to a urine sample which has proteins, it leads to formation of a white precipitate. Now this was about the qualitative estimation. Going to the quantitative estimation. Now quantitative estimation is needed for diagnosis of nephrotic syndrome, in which the value of protein excretion is very important for detection of something known as microalbuminuria, and also to follow the response to therapy in cases of renal diseases. We will discuss about the microalbuminuria in briefly. We will discuss it. Now what is it? It is excretion of 30 to 300 milligram per 24 hours of albumin in urine. It's very important to note only albumin is checked in this case, and its level should be less than 300 but should be more than 30. It should range between 30 to 300 milligram. Now to test it, uh, normally tests which we are doing, they do not detect microalbuminuria, and it is very important to check for this because it is earlier marker for diabetic nephropathy and also a independent risk factor for cardiovascular diseases. So we can take either a early morning sample, or we can take a 24-hour sample for detection of microalbuminuria. And for that, mostly test strips that detect microalbuminuria are nowadays available, or we can go for radio immunoassay or ELISA, which are specific that they will diagnose the only the albumin part. This was all about the protein examination of the urine. We will discuss about the glucose examination and slightly about diabetes mellitus in my next video. Do like, share and subscribe, and ask any query regarding the topic. Thanks for watching this video.